Look at the patient's chest movement. Also notice that the saturation is low despite receiving supplemental oxygen.
There are situations in which just oxygen is simply not enough, and we also need pressure. Two devices which can achieve this in patients that are breathing on their own, spontaneously breathing, is the high flow nasal cannula and the non-invasive ventilator. We have started to say that high flow nasal cannulas use flows of 40 up to 60 liters per minute, which actually achieves PEEP, that is positive end expiratory pressure. Depending on the amount of oxygen we add, it can either deliver just room air at high flows or it can go up to 95%. The added advantage was that a PEEP could be achieved of 5 to 10 centimeters of water, which actually achieved some grades of alveoli recruitment. Examples of a high flow nasal cannula use was COPD, patients that have atelectases, or patients that have transudate exudates such as pneumonia or pulmonary edema. By administering extremely high flows of oxygen to the patient, this actually achieves a positive pressure inside the alveoli. The positive pressure from the alveoli, it will push out the fluid in situations of pneumonia and pulmonary edema back into the interstitium, so the alveoli can take part in oxygen transfer. In atelectases, it also opens up the collapsed alveoli and increases in general the surface area of the lung. As a result, the saturations of oxygen in patients will be increased. However, there are situations in which small positive end expiratory pressures are not enough. Sometimes COPD patients with severe exacerbations, such as pneumonia, have an increased work of breathing in order to overcome the narrowings of the bronchi and also to keep the alveoli open or reopening the alveoli with each breath. This work of breathing is translated in tachypnea and in muscle fatigue in the end, which results in respiratory insufficiency. To aid patients that are still breathing spontaneously but have an increased amount of work of breathing, we can use devices such as mechanical ventilators, which administer oxygen and also pressure through a tight-fitting full-face mask. On the right-hand side here, we have a full-face tight-fitting mask around the patient's face, which does not only prevent air mixing, but also allows pressure to build up. Not only inside the mask, but this pressure is now transmitted down to your patient's lungs. Why is this advantageous? Because not only that it can achieve positive end expiratory pressure, which can be set by you, it can also administer pressure support. Now, this pressure support, what it actually means is that every time the patient's brain triggers a breath, the machine down here senses the patient's breath and actually administers pressure as the patient is breathing in. So what this actually achieves in the end is a decrease in the work of breathing. Oxygen can be delivered from room air concentration all the way up to 100% oxygen due to the tight-fitting face mask. It uses variable flows of oxygen and mixtures of air with oxygen, depending on the patient's requirements. Non-invasive ventilators can be adopted in patients with COPD or pneumonia or pulmonary edema that have increased work of breathing. This is best employed early in patients with respiratory signs of respiratory insufficiency in order to early offload the work of breathing and prevent muscle fatigue, and in the end to prevent invasive ventilation.